Welcome, everyone. Thank you for joining us. Today, we are discussing one of the world's most consequential public health threats, Ebola virus disease. While remarkable progress have been made over the past decade in surveillance, vaccines, diagnostics, and treatment, recent outbreaks in Uganda and the Democratic Republic of the Congo remind us that Ebola remains a persistent threat requiring vigilance, coordinations, and community trust. The outbreak is evolving quickly, and this conversation was recorded on June 22nd. Our goal today is to better understand this current situation, the operational realities facing responders, and the lesson these outbreaks hold for global health security. I'm pleased to join by two dear friends and colleagues, Roseline Belizaire, Director of Emergency Preparedness and Response of the World Health Organization, WHO, Regional Office for Africa. She is also the WHO Incident Manager for the Ebola response. And then we also have Petra Corey, who is the Global Director of Health and Care for the International Federation of the Red Cross and Red Crescent Societies in Geneva. Welcome. So Roseline, we're going to start with you. Could you begin by providing an overview of the current Ebola situations in the Democratic Republic of the Congo and Uganda? And what should the global community understand about these outbreaks that may not be reflected in the headlines?
Thank you. So the current situation is serious, but it is important to look beyond the headlines numbers. In Uganda, the situation is relatively stable. There are 19 confirmed cases, of which 14 were imported from the Democratic Republic of the Congo, and around 100 active contacts that are under follow-up. There has been no major recent increase in transmission, but the cross-border risks remain important. While in DRC, in the Democratic Republic of the Congo, the outbreak is evolving rapidly. It is a community outbreak. So as of today, we currently have 1,003 confirmed cases and 254 deaths, representing a case fatality ratio of 25.3 across 24 affected health zones. So in Ituri province, the outbreak remains the epicenter, with 916 cases, or 91% of the total of cases. In the North Kivu, we have reported 84 cases, but remain a mortality hotspot, with a case fatality rate of 57.1%. In South Kivu, so far only 3 cases has been reported. So however, no new cases has been reported since the 26th of May in the North Kivu. As you can see, the outbreak in the Democratic Republic of the Congo has expanded in 3 provinces. So, what may not be reflected in the headlines is the complexity of the operating environment. This outbreak is unfolding in areas affected by insecurity, population movement, humanitarian needs, and community mistrust. Those factors make surveillance, contact tracing, safe referral, a safe and dignified burial, sample transportation, and community engagement much more difficult. At the same time, progress is being made. In the last 7 days, alert investigation improved from 76% to 90.9%. And recoveries have increased from 45 to 100, a new recovery in the outbreak. And isolation occupancy also decreased from 94% to 80.8%. So far, additional support has also been deployed to hotspot zone. We have operationally, we have shifted to a zonal response approach in Bunia, like in zones like Mongwalu, Rampara, and Yankunde. That means we bring coordination and decision-making closer to where transmission is occurring. And actually, we are going even deeper. We are doing micro-planification in the health zone, in the health areas. The major challenge now is to convert this improved response capacity into interruption of the transmission chains. Contact follow-up remains low. As of today, we are at a 58% against the target of 95%. Community deaths continue, and 425 samples are still delayed in transport to laboratories. That is where our focus must be.
Thank you so much. Petra, from the IFRC perspective, what are community experiencing on the ground? How do outbreaks affect daily livelihoods, education, and local health systems?
Thanks, Fong. And before I start, I just want to commend WHO for their leadership on this response, and also for the Ministry of Health of DRC and the relevant ministries. This has been one of the most challenging health crisis in the most recent years, particularly because this crisis, the health outbreak was declared when we've already had more than 3-digit cases, when in previous outbreaks, usually we start with 2-digit cases. So we are starting off with an extremely concerning outbreak. I think Mary Roseline, she gave a good framing on the situation in communities, but let me give more context here. We're talking about a complex crisis. This is a district. Eastern DRC has a humanitarian crisis ongoing, and now there's a health crisis on top of the humanitarian crisis. You have 4.8 million people that are in need of a humanitarian assistance. This is before the health crisis. You have a context where there is a conflict, more than 120 armed groups. You have 970,000 people displaced in 61 camps. You have one of the most poorest and fragile province. There is acute food insecurity in that district. The health services are suboptimal. Malaria is their number one killer in that region. Malaria is extremely endemic in that province. Access to healthcare is very limited. The health system is weak. This is all by baseline. Transportation is difficult. So people to receive health services, they need to move from one place to another, but the transportation is extremely difficult. Add to it that this is also a province with a high sexual violence rate, and extremely difficult for women and children. So put this in context. Now we're also talking about an Ebola health crisis for those communities. The first immediate challenge that we're seeing is the fear, grief, and uncertainty. Fear, because this is an Ebola species that we're coming and telling them it doesn't have a vaccine and doesn't have treatment, where they're used to the Ebola Zaire in the past. This is their 17th outbreak. So that species did have a vaccine, did have better treatment opportunities. So now we're giving them a whole new uncertainty. They're losing loved ones. There is a fear that if someone is suspected, then they're going to lose that someone because they're going to go into isolation and they won't see that person for a number of days. And there is a high mortality rate. Marie just mentioned 25%. So all of those are not good news for communities, and it propagates this fear and grief and uncertainty. And it doesn't help the second item, which is mistrust and misinformation. Because in that context of a humanitarian crisis and the fear that the communities are exploring, mistrust and misinformation spreads like wildfire. We are racing against it, and we can talk further around it. What's the result? The result is currently we have incomplete reporting of cases. Marie mentioned it, because we need to get into communities fast enough to gather and get the information. We have multiple unknown chains circulating. This all goes against what we need to do in containing an outbreak. We also have, as a Red Cross, Red Crescent, we have a duty of care for our staff and volunteers. We've already lost 3 volunteers to Ebola at the initial, before the outbreak was declared. And so we're being very vigilant. on the duty of care. These are areas that bringing the protective equipment, bringing the needed tools is difficult because of all what I explained in terms of insecurity issues and conflict challenges. So we're facing a situation where we're present in communities, but we're also trying to scale up against the odds within the communities. We are fighting misinformation, distrust, fabrication of news. We're also trying to protect our volunteers and staff as they scale up and they go within the communities. So it's a complex operation. As I said at the beginning, and Marie mentioned it, we have made progress, all of us. More needs to be done, but it's been 4 weeks, difficult 4 weeks for the colleagues on the ground. Marie is in Bunia. I've visited DRC, but the people that are on the ground are facing a lot of challenges there. Thank you.
Thank you so much, Petra. And, Marie Roseline, given the challenges that Petra and you just outlined, what concrete steps are the governments taking with neighboring countries and inside to improve the situations, improve coordinations, and prevent cross-border spread?
Well, thank you also for the question. So as Petra mentioned, you can see that the situation is very complex, and the community also is suffering, not from Ebola, but for this long-term humanitarian situation, this long-term displacement because of conflict. And the government is really working together with all partners, and they are making, I can say, concrete step to manage the cross-border risk. First, there is an exit screening that's been reinforced at point of entries and point of control. The point of control are those internal. That means from a province to another, and even from a health zone to another health zone. So now we are seeing a point of control being implemented. As you see, the outbreak in Uganda has been, like I say, a consequences of movement from DRC to Uganda, the corridor. So far in that corridor, particularly around Ahu, Mahagi, and Ariwa health zone, this has been a reinforcement of the check-in at exit point. The border is closed so far, but we still have a movement of goods, and that we still have to check the truck drivers and also those people that have to work at those borders. So as of 16th of June, so we have a 44 of 55 sites that are functional and that has been reinforced. That means with 80% of our travelers screened. We have some resistance also at point of control and point of entry, mostly at point of control, where the population is asking, why should you screening me? Because I'm just coming from internal health zone to another health zone, and some of them refuse the screening. However, it is a very small number. So what I can say is that this site, they support screening, hand hygiene, risk communication, and alert detection and referral of suspected cases. So far, we have been, a significant numbers of alerts that are coming from the point of entries and point of control. The second thing the ministry, the government is doing is that the ministries of health of DRC and Uganda held a cross-border meeting in Aru to review the epidemiological situation, assess mobility risk, and agree on a joint cross-border response plan. So far, the MOU between the government in DRC and the government of Uganda has been signed yesterday. So this MOU covers early warning, data sharing, regular coordination, surveillance, laboratory, infection prevention and control capacity to establish in both sides, risk communication and community engagement, and also case management of confirmed cases that will be doing in a joint team. And thirdly, we have also readiness is being a strengthening in neighborhood and district and also in country at risk. So that is the focus on rapid detection. Isolation, we are looking if each country is at the border is having at least one place to isolate. We are also having safe referral and community engagement activities ongoing in all those communities. And finally, we have our partner, IOM, with supporting on population mobility and also to identify the most active movement corridors and guide where screening, surveillance, and preparedness should be prioritized.
Thank you, Maria. Petra, you had mentioned earlier about safe and dignified burial. What are responder asking community to change, and how can teams approach these practices in a way that is both safe and respectful? And then also some of the challenges you mentioned about security and the risks that the responder are experiencing. What support do frontline volunteers need to keep working safely and effectively?
Thanks, Fong. When we talk about the Ebola virus in deceased bodies, the virus is still in the fluids. And so handling those bodies does require special way for burials. And that way it goes against the religious, traditional, and cultural way that communities do. It's a very difficult task and activity when we do safe, dignified burials, because you're asking communities and loved ones not to say their goodbyes the way they usually do it, and the way it's done, it could be perceived as disrespectful to the deceased, because our volunteers and staff and those involved in the burial process, they come in with protective equipment to handle the body, and we don't allow families to come closer. What we have done in previous and learned it from previous outbreaks, because we engage with communities, we've changed some of those practices. So an example of how we changed the body bags, we've introduced windows in body bags so that loved ones can see their beloved. And that this one came because in previous outbreaks, there was also question marks about harvesting organs from the deceased, and that this is not the actual deceased person, but someone else. So there was a lot of skepticism going. That's one thing we've introduced is the window. The other is the color of the bags. We've changed the color of the bag to white. So based on feedback we got from communities. But the challenge remains extremely difficult when we do safe and dignified burials. In DRC, in the Ituri district, so far with the North Kivu and South Kivu, the DRC Red Cross has done so far 206 safe, dignified burials. When they were conducting those 206 safe, dignified burials, they've had major insecurity incidents. We've had one incident where 10 of our volunteers were attacked and 3 were severely injured, and they required medical evacuation to Kinshasa from Ituri. And because all of this is because we're working in a context of misinformation, disinformation, skepticism is high. We spoke earlier, we mentioned the fear, we mentioned the lack of treatment, the lack of vaccine. But it's also important that we highlight that in those districts, the economical hardship is fueling a lot of this misinformation, disinformation. When you're working in a context that people are worried about bringing food to the table, they downplay Ebola risk. These people have been suffering for long periods of time from underinvested health systems, underinvestment in their community systems. And they look at Ebola as once we have Ebola, suddenly resources comes in. So they're skeptical also about this. When there is an outbreak, resources suddenly are available. And the skeptics of the response, they start fueling it as a money-making for organizations and for governments and for officials, which doesn't help us. So we're working in a context that we need to heavily engage with the communities to pass the right messaging. So far, 75,000 people have been reached through risk communication, community engagement by the DRC Red Cross. More than 10,000 door-to-door visits have been done. And those door-to-door visits are important because households are multiple people, not just one and two. So when you go to the house, you're discussing it with multiple individual and not with one person one-to-one, but rather having more of an engagement approach. Faith leaders have been engaged, community leaders have been engaged. A lot of effort is being put around communities. We always say epidemics start and end in communities. And that's where we are heavily investing at the moment to make sure that we respect communities' traditional and cultural ways. But at the same time, we're ensuring that the infection prevention control measures that we need to put in place are in place to stop the outbreak from further growing.
Petra, I'm going to keep with you for a second because you just mentioned something really important. I think IFRC has been serving as a bridge between community and the formal health systems. So what investments are needed to strengthen the resilience before the outbreak occurs?
We have been, as you said, for years. I mean, the IFRC came out of the first Spanish flu. That was why they created the Federation and the Federation for Red Cross, Red Crescent. And over years, we've explained and re-explained that community health systems are highly needed. When this outbreak was declared, the community-based surveillance was not at the level it needed. And that's why the virus circulated for weeks before we were able to identify it. We need to invest in those systems. When we talk about contact tracing and case identification, we're talking about going within communities, collecting the information and sending signals to ministries of health and health authorities to receive the direction on how to do with case referrals. When we talk about developing trust, you need to be within the community before the outbreak starts. You can't show in a community suddenly at the door of communities and ask them to follow instructions and bypass the need to be present and the need to showcase them that you're with them during peace and wartime. You're not only with them during wartime, but when they need you for other health services. When we say that malaria is the #1 killer in that province for so many years, and people have been dying from malaria, they're used to the death. The death to them is not a new story from diseases. And then we come forward with additional risks on those communities, additional health risks. We've had in DRC, particularly for the last 4 years, we had the community pandemic preparedness and epidemic preparedness program. Unfortunately, last year with the budget cuts that we've seen and the dramatic drop in development health assistance, those programs had to be shut down and we had to scale back. So the capacity at the community level was scaled down dramatically. DRC had the 16th outbreak in Kasai end of 2025. We haven't even wrapped up the 16th outbreak. We're still operating in Kasai, trying to conclude that operation, but retain and sustain some of those community preparedness elements that we need to keep in place. Thank you.
Thank you, Petra. Roseline, just to change a little bit and discuss some positive developments. With regards to the recent developments in vaccines for the strand of Ebola, what promise do the current vaccine candidates hold? And then maybe if you can also touch on some of the challenges might arise in translating them into effective outbreak response as well.
Yeah, absolutely. So the Bundibugyo vaccine pipeline is promising, particularly with the mRNA and ChAdOx candidate that could allow faster evaluation and deployment during outbreaks. So advanced purchase effort by partners such as Gavi could also help secure supply. So however, impact will depend less on scientific promise alone and more on field feasibility. So we need a 2-dose vaccine, for example, is difficult to deliver in remote, insecure, and setting where wards, I can say transport or storage import, permit, and custom clearance may delay operation. So ring vaccination will also require a strong surveillance and contact tracing that should be very at the level of 95%, this target that we cannot reach so far. And while also broader vaccination will require adequate doses, stock management, registries, and follow-up system. And on top of that, we also need a community engagement. Will also be critical to explain why a different vaccine is needed for Bundibugyo Ebola and to protect confidence in routine immunization also. Because we can see that with the Ebola vaccine, so the community can lose trust in the routine of vaccination because we already have, a previous Ebola vaccination that took place in that community. And now we are telling them that this vaccine that you received was only for Zaire, and now you have Bundibugyo. So it was not the message that we give the time that we are vaccinating this community in the previous outbreak in 2018 and 2020. And ultimately, I think a vaccine must be integrated into treatment access, supply chain, train health workers, and research and readiness also to achieve a real outbreak impact. So far, this is where we are with the vaccine. But however, as I mentioned, it's very promising, and we should start doing those previous work in order when the vaccine is ready, so the community can also be ready to receive that vaccine.
Thank you, Marie. Petra, what responsibilities should be shared among national governments, international partners, donors, and university and civil society? Where is external support essential, and where does domestic investments and ownership needs to be strengthened?
I think one thing that we have to repeat, and we keep repeating, and we stress every time there is an outbreak, we cannot continue to operate in cycles of panic and neglect. And every time we have an outbreak, we start panicking. We see panic at the borders. We see that the solution is not closure of borders. The solution is longer-term investment in communities. The solution is building the structures needed at the community level to contain outbreaks. It's trust and engagement. It's access to healthcare. After the COVID, the Federation published the World Disaster Report. And we highlighted from that World Disaster Report 3 things: trust, equity, and local action. All 3 were the landmark of what do we need to do to prevent the same mistakes we did when we responded to COVID. I mean, Marie mentioned if we're now looking into a new medical countermeasure, be it a treatment or a vaccine, how are we going to convince communities if we don't have the trust, if we don't ensure equity of access in communities, and we don't ensure local action? We constantly work with partners, global partners, and domestic governments on prioritizing health as one of their investments in their populations. Looking at ministries of health budgets, you will see the difference between the budget for health and other ministries. The budget cuts that happened last year for the assistance on health was shifted to the defense. So we went from health to weapons, contrary to where we need to be investing. Instead of investing in health systems and investing in health assistance, we went to invest in weapons and in the departments of war and departments of defense. And that's not the message of a healthy community. Our message has been consistent that invest in longer-term community health solutions. And an epidemic anywhere is an epidemic everywhere. Borders will not prevent viruses from traveling across.
Thank you, Petra. Marie Roseline, the current cases are rising sharply right now. What indicators are public health leaders watching most closely today to assess whether the outbreak is successfully contain? And then how long do you think this current outbreak will last?
Well, this is a very good question. But before responding to it, I can give you an example of the closing the border will not really help. Between the DRC and Uganda, there's a very long borders and people are crossing by foot. And when we look at the data to see how they cross, because 90% of the cases in Uganda are imported from DRC. When we look at the data, they are crossing by foot. They are not crossing by car. They are not crossing by plane. They are crossing by foot. So just to give an example that what Petra is saying is really important when we consider, and mostly the borders in Africa, where community is signed, both borders are totally the same. They are living together. They are sharing together. They are married between each other. So there is a really, I can say, a life around the borders that we cannot separate, and now we cannot separate those communities. So now when we look at the indicators, what are we looking at in order to make a decision? So one of the things that we are looking at, the first is the contact tracing. The contact tracing, normally, if you need to cut the transmission chain, you need at least a 95% of contact to be followed every day. We also look at the high risk of contact, because between contact, those who have been, just visiting the patients when he was sick, or just caring for this patient, or just cleaning the body fluid. Those are not the same level of risk of contact. So we look at particularly those high risk contact. Are they moving? If they're moving, where are they going? If they are going, can we follow them where they go? So it's really important, and we look at all those data. The other data that we are really looking at now in this outbreak is the type of symptoms and sign. So what we find out is that 90% of the cases, they don't present hemorrhagic symptoms. They are presenting the same symptoms like malaria. Reason why it's very difficult to convince this population who has been suffering from malaria for so long to let them know now it is Ebola. Whenever you have a headache, whenever you have a small fever, you have to go to the healthcare center. No medication, no traditional healers. So there is not only, a change in the custom, in the habit of the community, but also in what they used to. And it is very challenging, and that should actually use to prepare our messages and when we are giving them to the community. Other aspect that we look at also is the bed occupancy, the alerts. So how many alerts that we are having? The alert, it is any signal from the community. And to establish the alert, we put a threshold of alert that we should receive every day from any village. And this threshold is actually set up by the number of malaria cases that has been registered in this community before the outbreak. So if we see we don't have this alert, so now it is where the community healthcare workers should go to look at what's happening. And we look at very carefully at those alerts that we receive every day. And when we receive them, we should make sure they are investigated. So when they are investigated, as we have a case definition, we should look at if those alerts correspond to the case definition. So this alert become a suspect case. And when the suspect case, so we look at also if we have enough bed occupancy, bed capacity, in order for those suspect cases to enter in a standard health infrastructure, where we can collect the samples and wait there for 48 hours in order for the sample to come. Other indicators that we really look at also is the community, how the community is coming. We were in Mongwalu on last Saturday with the Minister of Health and Minister of Communication. And one of the things that was really successful in that meeting is that when we met with the community leaders, they tell us that 80% of the community now is collaborating with the response team. So that was a very important indicator for us. But now what do we do with the 20% that is remaining? So now our effort should be focused on those 20%. And we look at those 20%, we find out those 20% are localized in places where they have rebels group. So how now do we put in place strategies how we can reach those communities? So, and also other indicator that we look at is the IPC, infection prevention and control indicators at hospital. We make some assessment we assess on 177 health infrastructure in Ituri. And between these numbers, only 4 have the capacity of preventing infectious and control inside this health infrastructure. So now we continue to look at those indicators because the prevention is not only in Ebola treatment center. The prevention is also in all health infrastructure. And as now the government has declared a free access to healthcare, so we should maintain this level of prevention in all those health infrastructure. So now those are some, I can say, key indicators that we are looking at, but we have a lot of sub indicators that are really we keep monitoring every day in order to know where are we going, what should we reinforce, and where should we put more effort in this outbreak.
Thank you so much, Marie. Roseline. I'm going to keep with you for a second because I just remembered that we were talking about the PDX system too, and when you were talking about some of these indicators, you're trying some really neat, new, innovative approaches. So, how can you explain more about that, and then also how those innovations could inform future preparedness effort across Africa and globally?
Well, thank you very much for the question. As you know, we are in the time of AI, and we cannot have a response when Outbreak without innovating new approaches on how we can better respond. So far, the PDX, we are using it in order to monitor spillover, on the outbreak. And so far, is indicating us all the alert that are coming, for example, from South Sudan. The other day we received an alert, and this alert fortunately has been negative, and we are so happy for that. And we are also looking at when a cross-border, because with the PDX, it gives us the movement in the cross-border, how many people are moving. And it is really interesting to see when using the Google map and the satellite to see how many people are crossing the border. Even though the border are closed, but we still, as I mentioned, we still have some movement because people are crossing by foot. So we are also using that in order to monitor the index of spreading of the disease, of spreading to other countries. So far we have, and also we monitor is that outbreak would become a pandemic, because then we also, with the new, the revised international health regulation, we introduce also not only the FIC, the public health emergency of international concern, but we also introduce the new concept of pandemic, and we also just have a publication in the Lancet where we mention, based on those tools, they show us that there is no criteria and no data that can prove this outbreak will become a pandemic. What is this? A good news. We also use the AI, and also now we are putting AI in place in order to support the contact tracing. Now we are putting that in the system where someone is crossing the border, just putting your name so we can know if that person is a contact. And then we can, not avoid the person to travel, but at least to increase the rate of contact and tracing that we are looking at in this outbreak. So there are so many, and also we have the tracker that you share with us also, that we can also implement in surveillance system that we are also trying to implement. So we have so many tools that we are developing, but the PDX is the principal one that we are using so far to monitor the spillover and also to monitor people movement across a border, mostly in the area affected by the outbreak.
Thank you so much for that, and that's incredibly exciting. Petra, I'm going to go back because you were really heavily involved with the COVID response. And so, we learn a lot of lessons from that. And so have those lessons translated into a stronger outbreak preparedness for Ebola and other emerging infectious disease?
Funga, we've seen time and time again, you cannot outrun, you cannot outwork, and you cannot outwait Ebola. And this outbreak has shown us that we have to do a lot more work before the next outbreak comes our way. If we need to learn anything from DRC, preparedness is not something we build during an outbreak. It's something we do before an outbreak. And when we discuss and have we have peer-to-peer conversations about the future of the health security file, outbreak diseases becomes at the core of this conversation. And the lessons we've drawn after COVID, they lasted 2 years after COVID, and then we pressed the reset button, and we're now reinventing the wheel again. I hope that we can all raise our voices one more time to repeat that what we learned during COVID, please let's not forget it. Yes, humans have short memory, but let's not forget what we faced, all of us, during COVID. Thank you.
I'm going to keep with you. So if there is one message that you like policymakers, practitioners, and the public to take away from today's discussion, what would it be?
Invest in preparedness and readiness. Don't wait for the next outbreak to start building the ship. Build it before time.
And Marie Roseline, what about you?
Well, I think my message will go in the same way because I can say, advocate for more investment in preparedness. Preparedness is not an optional investment. It is a must do, and what we are looking at now, and when I'm looking at the system where we are responding, it's totally a lack of preparedness. It's a collaborative failure of preparedness in the country. And the responsibility is for all of us, to come together in order to improve preparedness and save lives. And I'm sure if the system were more prepared and more sensitive to those kind of outbreak, we will not we wouldn't lose these 200 to almost 250 lives that we lose in this outbreak. So what I want to say to policymakers today is that please invest in preparedness because preparedness saves lives.
Well, thank you so much to our two distinguished guests. While Ebola outbreaks present significant challenges, they also demonstrate the importance of scientific innovation, community leaderships, international cooperation, and sustained investments in preparedness. The lessons emerging from Uganda and the DRC will help shape how the world responds to the future health emergency. Thank you and have a wonderful day.
Thank you.
Thank you.